I'm Peter Block in Orlando at the AHA annual meeting for On the Scene. With me is Ishtikhar Kulo from Mayo Clinic. And Ishtikhar has done a very interesting study concerning the genetics of associated with myocardial infarction and prognosis, the MI gene study. Ishtikhar, first off, why don't we tell folks what your study did?
So we measured genetic susceptibility variants in 200 individuals and created a genetic risk score based on those, but randomized the individuals to get just the routine conventional risk factor information versus genetic risk score plus the conventional risk factor estimates.
So what you did was give the patient their genetic risk score and their Framingham score, I assume, and then they said, okay, carry this back to your doctor and talk about it, or then what happened?
Well, this was disclosed by a genetic counselor, and immediately afterwards they met with a physician to engage in shared decision-making regarding statin therapy. And our main outcome was LDL cholesterol levels at 6 months after the disclosure of risk. And what we found was that in the genetic risk arm, the LDL cholesterol level was about 10 milligrams per DL lower compared to the ones that just got the conventional risk factor estimates.
So the shared decision-making, physician talking to the patient with both of them knowing what was going on, helped the patient. Why don't you just say, why don't you give everyone statins?
Well, we know what to do with the low-risk individuals, and we know what to do with the high-risk individuals generally. It's the intermediate risk group that we need more information, and indeed this trial was on these patients were all intermediate risk. So the purpose was to see if probabilistic genetic information can be utilized in a shared decision-making setting by the patient and the physician to arrive at a decision regarding statin therapy.
And then indeed their LDL, once they had that opportunity, did seem to go down.
Exactly, and that was entirely due to greater proportion of patients who received the genetic risk score being started on a statin therapy. Unfortunately, we did not see a decrease in dietary fat intake or increase in physical activity levels as a result of disclosing genetic risk information.
So the physician still has to beat up on them in order to change their lifestyle.
Well, as you know, Peter, it's always a hard thing to make patients change behavior.
Okay, but this is an important issue, though, because shared decision-making is sort of gaining a foothold, and I think we're going to see more and more of that. And if you can decrease LDL by having the patient involved with their decision-making, that can't be bad.
Exactly, and this was a case where you're giving them personalized risk information, in this case, genetic risk information, and in this setting, it was clear that physicians were able to use this information and patients were able to perceive it, and then to arrive at the shared decision-making of whether or not to start a statin medication.
That can't be all bad and may be a very good use of genetics going forward. Thank you very much.
It's a very exciting future. Thank you.